Hello, I'm Lawrence Klotz, professor of urological surgery at the University of Toronto, Sunnybrook Chair of Prostate Cancer Research. I've been involved with TULSA for many years, really since the inception of the concept, and it's a pleasure to talk to you about this today. The key concept of TULSA that makes it really unique is closed-loop temperature feedback control. The technology takes advantage of the real-time MR mapping. That means that as the ultrasound energy is delivered, the temperature in the tissue is mapped out by the MRI and fed back, and this controls the amount of energy and the duration of energy that's delivered by the transducer. It's a transurethral approach. It's a planar ultrasound transducer. There are 10 5-millimeter transducers in an array on the probe that's introduced into the prostatic urethra, each one individually controlled. The technology compensates for heat sinks, tissue, temperature resistance, and blood flow, so that really what you see is what you get. If the tissue reaches the target temperature, the effect has been achieved. There's also cooling of the urethra and rectum to protect them. So the components consist of the transducer you see here. It looks a lot like about an 18 French urethral sound with a flexible tip. It goes in over a guide wire, and it has these 10 5-millimeter transducers that are arrayed along a 5-centimeter length, which really is the length of most prostates. As the energy is delivered to the prostate, you see on the MR map a temperature change, and as the temperature increases in the radiated tissue and approaches the predefined target boundary, the energy is controlled and stopped in that individual plane when the thermocline reaches the boundary. The components consist of a robotic arm. All of this is, of course, MR compatible. A robotic arm which controls the device and rotates it, and can also be used to move it superiorly and inferiorly. Computer hardware, the energy system that generates the ultrasound energy and delivers it to the transducers, the surgeon console, and the various control systems that are present on the screen in the control room. And then the two disposable applicators, the urethral applicator, which contains the transducers and the urethral cooling, and the endorectal device that cools the rectum during the procedure. So this is done in the MR core. The patient is anesthetized usually just outside the MR suite, and lies on the gantry that's on a rolling stretcher that can be moved directly into the MR suite. A guide wire is left in the urethra, and a suprapubic tube if one is necessary. And the patient is then wheeled into the MR suite, and on the gantry, the urethral applicator is then placed over the guide wire in a sterile fashion and positioned roughly where one thinks it should be. And then the patient is moved into the MR core and imaged. And so the images show both the prostate, and then once the treatment is initiated, the thermal mapping images, and then at the end of the treatment, another MRI to confirm treatment efficacy. What I'm going to show in this remarkable slide is what TULSA looks like when you're actually doing the procedure. This is a man who had a 40 cc target area. The treatment took 38 minutes, which is fairly typical. It's speeded up. We won't have to wait that long to see the whole thing. And you will see on the right, there is a vertical bar showing the relationship between color and temperature. And the key element of this is that yellow indicates the tissue temperature of 55 degrees, which is essentially the tissue target. On the top row, you see for each one of the 7 slices, so this was a 3.5 centimeter long target area. Each slice has the target outlined in the brownish color there. The next little row that says E1, E2 shows the power in that slice while you are watching the procedure being administered. The third row shows the maximum temperature during treatment. If we can now activate this, you'll see this is considerably speeded up. But what happens is the energy is delivered to each one of those 7 transducers. You can see the yellow thermocline moves out to the target, which is in black, and then it stops. And if in any one of those slices, the 55-degree thermocline reaches the target earlier, then the energy to that transducer is simply stopped until the others have caught up. When the thermocline has reached the target in all 7 slices, maybe you can hit it again. The transducer, which is represented in black, starts to rotate. And essentially, this is the concept of the closed loop control. In other words, the thermal mapping drives the energy and drives the rotation of the transducer, and 38 minutes later, you have complete prostatic ablation. You would now look very carefully at each one of those slices. You're looking for hot areas. So for example, you can go back, if the cancer was in the right peripheral zone laterally, you can see slice E5, for example. There's a little blue area there. You can go back and deliver more treatment just to that area if you like. Then finally, the bottom row shows the post-treatment, post-gadolinium contrast-enhanced MRI. And this is where you see the dramatic effect of this therapy, that essentially there is no contrast in any of these slices, just a big black hole. This is a summary of the studies that have been carried out over the last roughly 20 years in the development of this technology. It began with in silico and gel modeling studies. I first got involved more than 10 years ago with canine studies, and we did about 35 dogs over a period of several years to look at how closely the targeted area corresponded to the actually ablated area. We learned from this that the precision was somewhere around 1.2 millimeters. We went on to do some treat and resect studies where we essentially defined a target, treated it, then took the patient to the operating room and removed the prostate. And again, this showed very tight concordance between the targeted area and the area that was thermally ablated. You can see in the bottom middle row there that in these cases, complete tumor ablation was achieved, even though in fact in these studies, we hadn't set out to necessarily eradicate the cancer. We were doing that with the radical prostatectomy. It was really to define the relationship between what is seen on the screen and what was seen pathologically, and this was a very tight relationship. Subsequent to that, safety and precision study involving 30 patients that was carried out in several different sites, and it showed really remarkable degree of safety as well as a very excellent PSA response with about, you see that on the top right, with about a overall about a 90% reduction in PSA in these cases. And then more recently, we had this pivotal TACT trial, which was the trial that served as the basis for FDA registration. This involved 115 patients, 13 clinical sites in 5 countries. Patients were aged between 45 and 80. They were mostly intermediate risk prostate cancer, but patients with large volume grade group 1 were also included. It was whole prostate ablation with sparing of the urethra and the urinary sphincter, so about 3 millimeters left at the urethral apex to avoid sphincteric injury. The primary endpoint was safety and also degree of PSA reduction, which was defined as more than a 75% fall in PSA. And there were a number of secondary endpoints related to prostate reduction, prostate volume reduction, the results of the prostate biopsy at 1 year, and MRI and quality of life. And you can see the distribution of prostate cancer on biopsy at baseline. The majority had grade group 2 disease, another roughly 20% high volume grade group 1, and there was about 15% of patients had low volume grade group 1 disease. And similarly, the distribution of the PIRADS, the majority of patients had a PIRADS 4 or 5 lesion. And here are the results of this study. So first of all, PSA reduction was dramatic. Pre-treatment median PSA of 6.3 dropped to a nadir of 0.3. So this is about a 95% reduction, and it remained at a very healthy, respectably low level, 0.53 and 0.63 at 1 and 2 years. There was also, and this is, I think, some of the most compelling results demonstrating the power of this technique. The prostate volume decreased a median of 91% from 37 cc's to 3 cc's as evaluated by MRI. That is dramatic by any standard. And these are the key oncologic outcomes. First of all, 93% of patients did not require additional intervention. 7% went on to something further, either a radical prostatectomy or external beam. Repeat TULSA was not offered as an option. The bottom graphs show the pathology outcome. So there was a persistent evidence of grade group 2 disease in about 15% of patients. There was persistent high volume grade group 1 in about 8%, and approximately 10% of patients had residual low volume grade group 1 disease. Overall, 65% had no evidence of any cancer, and amongst the patients who had pre-treatment grade group 2 disease, 79% had no evidence of residual grade group 2 disease. So another way of looking at this is about 80% of men had histologic improvement as a result of the therapy. The issue of pathologic miss, I'd say, is fairly moot in this scenario where the median volume was reduced to 3 cc's. I can tell you that the patients were mandated to have 10 cores, and to get 10 cores out of a 3 cc gland is a challenge. Multivariate analysis showed that there were some important predictors of grade group 2 persistent cancer on the 1-year biopsy. The first was the presence of intraprostatic calcification at baseline. And, this is not surprising. Calcifications do act as a shield and disperse ultrasound energy, so it's very plausible that the tissue beyond those calcifications did not get adequately ablated. approximately 85% of the patients who didn't have calcifications with grade group 2 were free of grade group 2 disease on biopsy. The thermal coverage during treatment, the patients in whom there were challenges to ablate the area had a higher risk of persistent disease. And of course, this disease did show up on MRI. So the patients who had a positive MRI at 1 year were more likely to have residual disease, no surprise. The patients who had a negative MRI, 96% of them had no evidence of significant cancer. So it's a very reliable assay in these patients. The safety was really excellent. The proportion of patients who had adverse events was low. Overall, about 7% had a serious adverse event, and by far the most common was a urinary tract infection. 4% of patients, about 1% each had retention, a urinoma, which meant a collection of urine in the prostatic urethra. Actually, this was my patient. It wasn't clinically significant. An ileus in one, a DVT in one, and a stricture of one. So this is a favorable safety profile by any reasonable standard. This slide shows the functional outcomes at 2 years. Incontinence was rare. There was really only one patient in the whole group who had persistent incontinence requiring more than 1 pad a day beyond 1 year. There was a transient effect on incontinence in about 35% of patients, but this had resolved by 6 months in the majority. And pad-free incontinence was 93% at 1 year. So this was really a rare event, and when it did occur, it was mild in all but one patient. Similarly, with erectile function, 83% maintained erection sufficient for penetration with or without PDE5s. About a quarter of the patients developed moderate ED, which was defined as having erections with PDE5s but not without. And there were no patients in the whole group who failed to respond to PDE5s. So this compares really very favorably to just about any other definitive treatment for prostate cancer. If you compare these results to surgery, radiation, or HIFU, they really look very promising. Lower rates of erectile dysfunction, lower rates of incontinence, low rate of stricture, 2.6%, really considerably better than HIFU and perhaps comparable to radiation, and no GI toxicity whatsoever. To summarize the results of this TAX study, 115 men, 2/3 intermediate risk. Most of the remainder had high volume Gleason 6. There was a dramatic reduction in PSA, in prostate volume, low rate of side effects, and a relatively low rate of residual clinically significant disease. The PSA reduction was stable so far for 2 years, which is the duration of follow-up we have on this study. Prostate volume decreased by 91%. At the 2-year follow-up, and this is actually new information, high degree of safety and quality of life preservation, no issues with rectal or bowel injury in any patient. 1% of patients have a long-term continence problem, and 83% have resumed sexual activity with erection sufficient for penetration. 7% of the patients required further therapy, and this is really comparable or superior to relapse rates with virtually every other therapy for prostate cancer. I should also add, this was the initial learning curve at these sites. Most of them had the first generation commercial device. There's been some further developments in the product since then. And as well, I think the results reflect the fact that this was a new technology and that all of the teams were learning how to do this properly. So this was complete prostatic ablation. The technology also lends itself very well to focal therapy, partial gland ablation, and so on. This slide summarizes the lesion-targeted TULSA experience to date, and this is based on 2 treat and resect studies, one that we did at Sunnybrook and one that was done in Finland. The same-day treat and resect study we did involved 5 patients who had a visible lesion on MRI, which corresponded to the cancer on biopsy. So in these patients, the lesion was targeted. You can see there the lesion at the right side of the peripheral zone in the black ink on the right, and the targeted area in light blue. And this is just a typical one of these 5 cases. And the 2 lessons from this study were that the ablation precision, the concordance between target and histologically ablated area was less than 2 millimeters, and it was complete ablation of the target zone, and this could extend out into the capsule if necessary. Antonin and colleagues in Finland have just recently reported a treat and resect study, which was chronic. So the TULSA was done 3 weeks before the prostatectomy. This was 8 lesions in 6 patients. They left a safety margin of 3 millimeters at the neurovascular bundle, and the findings were consistent. No viable cancer in the treated areas, targeted region totally ablated histologically, and they also noted an interesting phenomenon of thermal fixation in part of the ablated volume. And what this means is that the tissue is essentially glazed. It is heated so rapidly that there is no time for tissue changes to be seen, so that there were structurally normal cells on H&E, and viability studies demonstrated that these were indeed dead cells that were glazed and did not undergo any histologic changes due to the rapidity of treatment. So where is this going to fit? Well, it's really the question of targeted therapy versus whole gland therapy. We believe that this is a very good alternative for whole gland treatment for particularly patients with grade group 2 and 3 cancer, or perhaps patients with grade group 1 cancer who have DNA repair defect mutations in their germline. And then, of course, it's another option for partial gland ablation or focal therapy. The sweet spot is the patient with grade group 2 with a solitary lesion, preferably less than 2 centimeters. And in this kind of patient, focal therapy can be delivered with precision, with virtually no effect on the patient's quality of life, and can effectively eradicate the lesion. There's still going to be a role for surgery and for radiation for the high-grade patient with multifocal cancers, but we think that TULSA certainly has a role in the patients who have less aggressive cancer than those folks. There's a number of ongoing trials of TULSA. There's a BPH trial for men who have large prostates with the goal of preserving ejaculatory function. This may also be a 2-for-1 in patients who are undergoing focal therapy for prostate cancer. There's also studies going on now of targeted therapy with either hemi or focal ablation, or a kind of subtotal ablation with more aggressive urethral sparing. Finally, salvage study in patients who have post-radiation recurrence or patients who have locally advanced disease and require palliation. Finally, part of the appeal of the TULSA technology is its flexibility. You can use it for complete prostatic ablation, analogous to surgery and radiation, for salvage therapy in radiation failures, for focal or partial gland ablation targeting a specific lesion, in patients who have locally advanced disease for palliation, and even for the targeting of the transition zone in patients who have BPH. So in this talk, I reviewed the results of the initial treat and resect and subsequent safety, efficacy, and finally the TAC trial, showing really a remarkable degree of safety, efficacy, and oncologic benefit with this new technology. Thank you for your attention.